So I think we should carry on that discussion, you know. So next, I'd like to invite Dr. Tushar. Dr. Tushar Agarwal, who would be speaking on corneal lenticule extraction, current paradigms and future direction. So this is with regard to SMILE. And with regard to SMILE, before you start, I had a question. In the sense, we saw Dr. Sujit's graph, where slowly you see a progression of reports of ectasia in SMILE. So my question was, is it because SMILE was considered to be so safe that sometimes you can overlook some of the stringent criteria that we push for PRK and LASIK? Is that why it's happening?
I'm not aware of the graph itself, but it would be good to look at the percentage A, because the numbers have gone up. You know, it was, if in India, of course, it was introduced about 3-4 years before the US. It got FDA approval in 2016, and you know, once it gets approved in US, they just fall into the latest technology. So you're talking about the absolute numbers, or you're talking about the percentage on the base? Because the base would have gone up significantly after 2016. Yes, so number of cases, absolute number you do expect, because once the technology is approved in US, their numbers are totally different than our numbers. They're very, very high. So, yeah, yes. So that, you know, sort of explains it, because you do expect the percentage, I think, is the more important factor. That needs to be seen. So that was my hunch. So thank you. Thank you very much. So I'm presenting this talk on behalf of my colleague Professor Rajesh Sinha, who couldn't be here because of some personal emergency. So I actually went over this talk with him last night over the phone, and I'll try to do justice with it. So now this has been covered by the previous speakers, that initially the laser refractive surgery began with surface procedures, PRK, epi, LASIK, etc. Then the microkeratome came into picture, where a manual electric microkeratome was used to create a flap, and then the laser was done, which was called LASIK. Then we shifted to an all-laser system, where the flap also was created by the femtosecond laser, and then the ablation was done on the bed. And then finally we have landed with the SMILE, or flapless laser vision correction system. So it basically entails that you create a lenticule which accounts for the amount of refractive error. So it creates the amount, so it will separate out a tissue intrastromally by the use of a laser, which is directly proportional to the amount of refractive error which you want to correct. So you can just have some random figure for understanding that, okay, 20 microns per diopter, so, or 30 microns per diopter, and so the higher the refractive error, the thicker the lenticule, and you, instead of just vaporizing that tissue, you create that lenticule and you remove it through a small incision. So this, as I said, this was approved in 2016 by the FDA for myopia and myopic astigmatism. So you create the lenticule with the help of a laser, and then you have to do a manual separation, because it's not cutting, the laser is not cutting in a tangential manner, it is just creating a multitude of spots, you know, in two different planes. So there are micro adhesions between each spot, which you have to dissect out manually, and then you have to extract it. So this was the pioneering system, the Visumax. It can create various types of incisions in the cornea, so you can actually create flaps and do a flap based surgery also. You can do customized keratoplasty, you can do intracorneal ring segments, and then you have SMILE. So this is the geometry of the lenticule which I was referring to. So although it's a flap-less surgery, but you do need an area to access that lenticule. So in the initial part of the learning curve, we used to have a side cut of around 4 millimeters. And as you progress, you can continue to decrease the size, and you need a minimum size of 2 millimeters into the cornea to remove this central lenticule. Optical zone is 6 to 7. The rest of the parameters are similar to LASIK. So this is a short video which shows the procedure. So the docking is done with the PIS system. So what is happening is that the laser is firing, and it's cutting in two different planes. So first it cuts in the bottom plane, and then it cuts on top of it, because once a plane has been created, the laser cannot go beyond that. So you first create the posterior plane, then you cut the anterior plane, and this is all undergoing in about 15 to 20 seconds time. Following this, you open up the incision. So this is a full this incision is going through the anterior cap, and then you open this incision. We used to also use, I think this is his older video, we used to make side ports, which we have stopped. And then this is the trickiest part, and the one which involves the most of the learning curve. So now you have to separate the lenticule intracorneally, both from the posterior and the anterior side. And this is what requires the most amount of training and patience. So you first separate it from the anterior side, and then you go in below the lenticule and on top of the stromal bed, and then taking care to sort of reach the entire edges. So your goal is to now separate the lenticule completely from all sides. Now, in this particular case, I saw that you can use forceps to remove the lenticule. It can also take care of the adhesions on the side. But now, mostly once you go beyond 20-30 cases, you don't need these forceps. You just dissect the lenticule completely from the anterior and posterior side, and it can just come out with that. We normally do try to sort of unfurl the lenticule on top of the cornea. And especially if you're not sure, if you have left some part behind, you can unfurl the lenticule on the top of the cornea and just see whether you have removed the entire thing or not. This is an intraoperative sort of a slit lamp kind of thing, which is also there. You can examine the interface for any debris or any sort of left out lenticule. And finally, you can just use a wet sponge to smoothen out the area of entry. Okay. So these are a few of the initial results which were published. So in this particular study, the authors studied two groups of patients, one consisting of mild to moderate myopia up to 5 diopters, and other higher degrees of myopia. And as you can see, compared to the low to moderate myopia, where 93% patients had UCV of 6/6, only about 75% of patients beyond 7.5 had a vision of 6/6. No, sorry. Yeah. So these were more of a long-term results of 5 years, and they also concluded that this procedure is safe and efficacious. As you might have noticed, you are removing a central lenticule. So this procedure theoretically was not possible for hyperopia, and even still it's not approved for hyperopia, but people have started now working on actually treating hyperopia. If you have seen hyperopic laser vision correction, you actually need to steepen the central cornea, and you do this by removing more in the periphery rather than in the center or in an annulus form. So now people have started work on this, where the lenticule is shaped in such a manner that the center is very thin and the periphery in a ring form is quite thick. And once you remove that shaped lenticule, you can actually treat varying degrees of hyperopia. But as with all laser vision correction, hyperopic corrections, the results are suboptimal as compared to myopia. I'll take 3-4 minutes more. Couple of points about the learning curve. This has a steep learning curve as compared to LASIK. You do need about 15 to 20 cases to be quite confident. Compared to LASIK, the easier cases are those which have a higher degree of refractive errors, because the lenticule will be thicker. The smaller degrees of refractive error, you get a very thin lenticule, so you might find it actually difficult to remove. And the initial cut, you can also try a flap-based lenticle extraction in the first few cases, where you can actually lift up the entire flap and have the stromal bed to yourself, and then make the dissections. And then you can proceed to 4 mm side cut. It gives you a lot of room to move around your instrument to do the dissection. And once you are confident, you can go to lower degrees of myopia and lower degrees of refractive errors. Okay, so a couple of points. Now, the prime problem with this technique was that when you talk about astigmatism, there is no cyclotorsion control. So if the eye rotates or intorts during the laser, there is no accounting for that, which you do have in LASIK systems. So now the newer system, which is Silk, and there is one more system, yeah. So these both have two advantages. They are using lesser amounts of energy, and also they have cyclotorsion control built in, so even higher degrees of astigmatism can be treated reliably. Previous to this, more than 1.5 diopters of astigmatism weren't very reliable enough to be treated by SMILE. And this is a similar thing. And thank you very much. I won't repeat the same things again. Thank you.
Thank you very much for the talk. It was a very nice one. You mentioned about the Silk, where you can perform the same with the same equipment. You can do the Silk.
No, I think it's some different manufacturer.
Oh.
Silk is not on the Visumax platform.
Well, the only problem, the only torsion.
And the pupil centration also.
Oh.
There is no tracking in the SMILE system. So,
Okay.
so both things are there. So you can have a pupil-centered ablation, and plus you can have cyclotorsion control. So there is no registration in the SMILE. So that was a major issue. That's why the results with especially higher degrees of astigmatism, where cyclotortion actually comes into play, is not useful.
And theoretically speaking, that the ectasia should be less in case of. But what is your experience?
Yeah. So.
Because the stability of the corn.
So it's a question of what your true belief is. If you believe that the cutting of the moments is also responsible for ectasia, then yes, it should be. But if you see the data, why do we stress more on because why do we stress more on the bed? So the bed, the stromal bed thickness is same. The criteria are the same. The same kind of thing is there. So ectasia, I think, are theoretically similar. Of course, the major advantage is the sort of almost the non-occurrence of dry eye, which you quite often get, especially once you cross 25 years of age. In the patients, you get a lot of dry eye, and they need to be on lubricants for up to an year. So that dry eye problem is not there with SMILE at almost zero. So that's the major advantage. But ectasia, I'm not sure if there is a...
because in LASIK, because of the flap, even after 20 years, you can lift the flap, same flap.
Yes, so flap, that flap is like a permanent contact lens. Even with trivial trauma, it can come out if there is something, even a finger hits or something. So all those advantages are there in any kind of contact sports. Even army men, SMILE would be would be preferable to LASIK, because that flap even VR surgeons I have seen, a lot of times if these patients undergo VR surgery for some reason, later on the flaps come out on the table, and a lot of times they don't even realize that they have removed the flaps. They just rub it and throw the things.
That problem is not there. Still, ectasia is almost same. No, that's what I'm saying.
Yes, that's what I'm saying, because the bed is what is, I think, what you're leaving on the undersurface is, I think, the most important thing. If you're leaving a thinner bed, you will have ectasia. It's not the cutting of the moments which is causing ectasia, I think.
Even otherwise, in certain cases, even the bed was more than 400 microns.
Yeah.
And after 4 or 5 years, patient got ectasia.
Absolutely.
So there are so many unexplored factors.
So no one has been able to correctly predict who will get ectasia. That's the biggest problem. If you look at any paper in ectasia, so many case reports perfectly. I mean, corneas of more than 600 plus, having undergone LASIK for 2.5 diopters of myopia, still getting ectasia. So there is no definite pattern which is observable or sort of identifiable that okay, this is, and even these criteria which have been made, I'm sure because you can't do a prospective study on this. It's almost next to impossible to do a prospective study on ectasia solely. So it's all retrospective data that once you get ectasia, then you go back looking, okay, what was wrong? What did we, or what was done actually? We have seen ectasia in a couple of patients who turned out to be hypothyroid. Now, does hypothyroidism cause ectasia? I don't think so. So those were incidental associations, and this is just a compendium. If you see the literature, it's all a compendium of anecdotal evidence that someone publishes 6 reports, someone publishes 2 reports, and then you combine all those data. So I think that's the major issue with the regarding the finding the etiology or prevention of ectasia. The attention is focused more on treatment now than on prevention. At least we can treat ectasia now. There are multiple options.
Any question? After your SMILE procedure, suppose there is a regression.
Yes.
What will be your line of action?
So,
whether you go elastic or PRK or anything.
So if the question is that if there is a regression after SMILE, what are the options? You don't go, and do another SMILE. Basically, either you do a surface-based procedure or you do a LASIK. My preference, personal, would be to do a surface-based procedure after that. Simply because then you can do a topo-guided laser enhancement. And second, you don't end up with 3 interfaces then. Otherwise, you have now 3 levels of the cornea. So you have one bed, then you have an intervening stroma, then you have a LASIK flap. So I don't want that in the patient. It will definitely lead to loss of contrast. As such, their contrast is compromised after any laser. And if you create one more interface, it will create a bad contrast. So my preference would be to do a surface-based procedure if at all required. Even if there are complications, sometimes you lose suction halfway through, something like that. My preference would be to shift to a surface-based procedure at a later setting, rather than creating one more flap in that patient where there is already the interface has been created.
There is a remote chance of haze formation also.
Sorry?
Corneal haze formation for PRK. Not a remote chance is there.
So now everyone is advocating routine use of mitomycin for all cases of PRK. So we are using mitomycin C in all cases of whenever we have to do PRK. And unless you're talking about refractive errors of more than 4 or 5 diopters, then we don't see much of the haze is not much of an issue with PRK. But I think it's coming back again. The cycle has now come back again to surface after having seen flaps and everything, flapless, this, that. Everyone has realized that LASIK, no, I am finished. So, talk is the next speaker. I'm finished. I'm just carrying on. Thank you.
Thank you.
Lenticule placement? No. Actually, in fact, Dr. Rajesh Sinha is doing a lot of work in this. He is doing lenticule placement for management of keratoconus. So he is putting shaped lenticules intrastromally in keratoconic patients. So he is creating lenticules with the help of a femtosecond laser from donor corneas, and then creating an interface in the patient, and then placing those, I think 150 micron or little more lenticules in the cornea. Dr. Namrata Sharma is doing the same with bioengineered corneas. Placement of basically you add stroma to the previously existing cornea, but I am not sure about the hyperopic correction with that. Is it working?